Dear viewers and friends, hello and welcome. Today we are going to unveil a medical mystery that affects the health of hundreds of millions of people worldwide, the complex network of hyperlipidemia and related diseases. This is not just a simple numbers game, but a life and death medical battle. We stand at a crucial turning point in cardiovascular disease prevention and treatment. From diabetes to thyroid disorders, from kidney function to drug side effects, every link is closely interconnected, forming one of the most challenging treatment puzzles in modern medicine. First, let's talk about the dangerous duet of diabetes and hyperlipidemia. The report from the Lancet Diabetes and Endocrinology Journal in 2024 has dropped a bombshell in the global medical community. This meta-analysis covering large-scale randomized controlled trials revealed a paradoxical fact. Statins, this miracle drug that has saved countless lives of cardiovascular disease patients, may actually increase the risk of new-onset diabetes. Research data shows that among statin users, the risk of new-onset diabetes increases by approximately 9 to 12%, with high-intensity statins potentially carrying risks as high as 20%. Among every 100 to 200 statin users, one additional case of diabetes will occur within 5 years. But here's a key finding. Most patients with new-onset diabetes already had baseline blood glucose values close to the diagnostic threshold. In other words, these patients were already on the edge of diabetes. The latest research revealed the molecular mechanism of this phenomenon. Statins affect insulin sensitivity, reducing it by approximately 24%, while simultaneously decreasing insulin secretion by about 12%. This double hit creates the perfect environment for diabetes induction. Let's look at a real case. 55-year-old Mrs. Chen, who has had type 2 diabetes for 5 years, with a glycated hemoglobin of 8.2%, LDL cholesterol, that's the bad cholesterol, as high as 180 milligrams per deciliter, HDL cholesterol, the good cholesterol, only 32 milligrams per deciliter, and triglycerides reaching as high as 350 milligrams per deciliter. This condition is medically termed diabetic dyslipidemia, characterized by elevated triglycerides, reduced HDL cholesterol, and increased small, dense LDL particles. Next, let's explore hypothyroidism, this hidden lipid killer. Thyroid hormones are the chief commanders of the body's lipid metabolism. When this commander fails, the entire lipid metabolic system falls into chaos. Thyroid hormones T3 and T4 regulate blood lipids through multiple mechanisms, including regulating the activity of rate-limiting enzymes in cholesterol synthesis, affecting LDL receptor expression, regulating lipoprotein lipase activity, and controlling bile acid synthesis and excretion. The latest published systematic review shows that among patients with hypothyroidism, 38.6% exhibit thyroid dysfunction. The most common is subclinical hypothyroidism, accounting for 27.2%, overt hypothyroidism accounts for 8.1%, and subclinical hyperthyroidism accounts for 3.3%. Research shows that levothyroxine treatment brings dramatic improvements. Total cholesterol significantly decreases, LDL cholesterol markedly improves, HDL cholesterol moderately adjusts, and triglyceride levels decline. A patient diagnosed with primary autoimmune overt hypothyroidism combined with mixed dyslipidemia after receiving levothyroxine treatment showed shocking results. After thyroid function normalization, the lipid profile achieved significant improvement, ultimately even discontinuing statin therapy. Now let's look at chronic kidney disease, this special battlefield of lipid management. The Kidney Disease Improving Global Outcomes Organization released the latest guidelines in 2024, providing a clear roadmap for lipid management in chronic kidney disease patients. Chronic kidney disease, dyslipidemia, and cardiovascular disease form a dangerous triangular relationship. Stage 4 and 5 chronic kidney disease patients have significantly higher risks of thyroid dysfunction compared to stage 3 patients, and hypothyroidism is a risk factor for chronic kidney disease occurrence, progression, and mortality risk. Chronic kidney disease patients exhibit a unique pattern of dyslipidemia. Hypercholesterolemia accounts for 34.4%, low HDL cholesterol accounts for 34.1%, suboptimal LDL cholesterol accounts for 35%, and hypertriglyceridemia accounts for 36.6%. For patients over 50 years old with advanced chronic kidney disease, the guidelines recommend statins or statin-ezetimibe combination therapy. This is a 1A grade recommendation. Next, let's discuss the revolutionary advances in drug therapy in 2024. The European Society of Cardiology released the latest guidelines establishing a stepwise treatment approach. Step 1 is maximum tolerated dose of statins. Step 2, if targets are not met, add ezetimibe. And Step 3 is PCSK9 inhibitors. Ezetimibe, this underestimated therapeutic star, was featured in a blockbuster meta-analysis published in Mayo Clinic Proceedings in 2024, including 108,373 very high-risk patients, revealing stunning results. Combination therapy compared to statin monotherapy achieved an additional LDL cholesterol reduction of 12.96 milligrams per deciliter, 19% reduction in all-cause mortality, 18% reduction in major adverse cardiovascular events, and 17% reduction in stroke incidence. PCSK9 inhibitors also had major breakthroughs in 2024. The Pursuit Phase 2 study published in JACC Journal Devolutionary Progress, AZD0780, the first oral PCSK9 inhibitor with once-daily oral dosing, can be used in combination with statins, with efficacy and safety comparable to existing PCSK9 inhibitors. The global PCSK9 inhibitor market was valued at approximately $2.5 billion in 2024, with projected compound annual growth rate of 19% from 2025 to 2034. Now let's focus on a commonly overlooked issue: drug-induced dyslipidemia. The 2024 Korean Society of Lipid and Atherosclerosis Consensus Statement was the first to systematically address secondary dyslipidemia issues, with drug-induced dyslipidemia occupying an important position. Corticosteroids are dose-dependent double-edged swords, affecting lipid metabolism through multiple mechanisms, including causing hyperglycemia in the liver, increasing very low-density lipoprotein production, and enhancing hepatic lipogenesis. Studies in post-organ transplant patients show that prednisone increases LDL cholesterol levels in a dose-dependent manner. In systemic lupus erythematosus patients using prednisone, LDL cholesterol levels increased by up to 20%. Beta blockers provide cardiovascular protection but at a cost. Meta-analysis results from 315 trials showed triglycerides increased by an average of 30 milligrams per deciliter, and HDL cholesterol decreased by an average of 4 milligrams per deciliter. Non-selective beta blockers may reduce HDL cholesterol by 10 to 20% or increase triglycerides by 20 to 50%. Thiazide diuretics cause dose-related short-term effects, with LDL cholesterol increasing by 5 to 15%. This is a known show, RT term effect. High-dose thiazide drugs, that is, more than 50 milligrams per day, increase total cholesterol by 4%. Regarding major updates in international guidelines in 2024, while the 2019 European Society of Cardiology, European Atherosclerosis Society Dyslipidemia Management Guidelines remain the latest comprehensive guidelines, the 2024 position statement provided important updates to treatment strategies. The lower is better strategy was strengthened. Very high-risk patients should have LDL less than 55 milligrams per deciliter. Selected very high-risk patients should have LDL less than 40 milligrams per deciliter. And high-risk patients should have LDL less than 70 milligrams per deciliter. Early use of combination therapy was also emphasized. Practical guidance recommends that statin-ezetimibe combination therapy is the preferred approach for managing high LDL cholesterol. Very high-risk patients with high LDL cholesterol are unlikely to achieve targets with statins alone and should preemptively use combination therapy. Looking to the future, we are moving toward precision medicine-era lipid management. RNA interference technology brings revolution. Inclisiran, this siRNA drug requiring only 2 injections per year, targets PCSK9 synthesis and brings revolutionary improvement to patient adherence. The potential and challenges of gene editing technology coexist. The CRISPR-Cas9 system has enormous potential for treating familial hypercholesterolemia and lipid management, but ethical and safety considerations still require long-term evaluation. Artificial intelligence-driven individualized treatment is also worth anticipating. Machine learning applications in lipid management include individualized risk prediction models, drug response prediction algorithms, and adverse reaction warning systems. Integration of digital health tools, including real-time monitoring by wearable devices, therapeutic assistance through mobile apps, and popularization of telemedicine platforms will all change how we manage lipids. Let me summarize the 5 key findings in lipid management for 2024. First, the stepwise revolution in treatment strategies. From statins first to stepwise combination therapy, 2024 evidence supports earlier and more aggressive combination treatment strategies. Second, precision in individualized treatment. From one-size-fits-all to tailored, individualized treatment based on genotype, phenotype, and risk factors has become mainstream. Third, systematization of related disease management. The interactions between diabetes, thyroid diseases, chronic kidney disease, and dyslipidemia have gained deeper understanding and more systematic management. Fourth, normalization of drug safety monitoring. Understanding of safety issues, such as statin-induced diabetes and drug interactions, has further deepened. Fifth, breakthrough progress in innovative therapies. Oral PCSK9 inhibitors, RNA interference technology, and other innovative therapies have opened new possibilities for future treatment. The medical research of 2024 has painted a completely new blueprint for lipid management. This is no longer a simple cholesterol-lowering game, but a complex treatment network involving multiple systems, multiple diseases, and multiple drug interactions. From diabetes patients needing to balance the cardiovascular benefits of statins against diabetes risk, to hypothyroid patients potentially achieving significant lipid profile improvement through thyroid hormone replacement therapy alone, to chronic kidney disease patients requiring special dose adjustment strategies. Every decision requires precise, individualized consideration. This is an era full of hope. The emergence of oral PCSK9 inhibitors, strengthened evidence for ezetimibe combination therapy, breakthroughs in RNA interference technology. These innovations bring unprecedented treatment choices to patients. This is also an era requiring caution. Drug-induced dyslipidemia, complex drug interactions, treatment trade-offs in different disease states. These challenges require us to make clinical decisions in a more scientific and precise manner. Lipid management in 2024 has entered the era of precision medicine. Future treatment will no longer be standardized protocols, but individualized strategies based on each patient's unique genetic background, disease state, risk factors, and treatment response. This new era requires continuous learning by healthcare professionals, active participation by patients, and coordinated cooperation of the entire healthcare system. Only in this way can we truly achieve the goal of precision treatment, individual benefit, providing the most suitable lipid management plan for every patient. Thank you, dear viewers and friends, for watching. We'll see you next time.